So that's his specialty area of interest. Especially diffuse large B-cell lymphoma, which is what we think this is based on the pathology that they have at the other hospital. So he's very happy with how everything's gone. We looked at that fluid around the spine, and it doesn't look like there's lymphoma in there at the moment, so that's good.
Okay.
But because of where his lymphoma is, including it involves his adrenal glands, that actually makes him a very high risk for the lymphoma to be able to spread into the fluid around the brain. So how we prevent that is by giving him chemotherapy that can reach the CSF, or that fluid around the brain. That can be done two ways. One can be done with a medication called methotrexate through the IV, but we have to give it very high levels, and we can't give it with bad kidney function. So at least for this cycle, because his kidneys are still recovering, although we do expect them to recover, right now we can't give it to him because it would be too toxic because his body's not clearing fast enough. Okay?
Okay.
So the other way we do it is by giving chemotherapy into that spinal fluid by spinal tap like we did the other day.
Right.
And since we can't do the methotrexate this cycle through the IV because the kidneys are recovering, he does want to go ahead and give it into that fluid by a spinal tap, just so we don't get behind.
Okay. And
Okay?
would it be the same cyclophosphamide and vincristine that he had for the traditional, or do you do something different? Or is it
Absolutely not.
No.
In fact, those chemotherapies are toxic and can cause death if we give them into the spinal fluid.
Okay.
So chemotherapy that we give into that fluid can only be certain kinds.
Okay.
There's two medications. One is cytarabine and one is methotrexate, the same one that we do through the IV, but at a much lower dose. And it doesn't have to be as high because we give it directly into that fluid.
Right.
The good thing about the spinal fluid is there's a barrier that prevents things from going from the blood into that fluid, which in general is good. It prevents bacteria or viruses that you might get from getting in there. Bad thing is it prevents most chemotherapies from getting in there. So that's why we have to give this directly into that area. And I did want to go over the medication with you, methotrexate, including side effects.
Okay.
And I'll go over all the side effects for methotrexate, but just bear in mind, most of the side effects come when we give it through the IV. When we put it into the CSF, because it doesn't get throughout his body, you don't generally get the side effects. Okay? But I'll go over all of that real quick with you. So, first of all, it's just another spinal tap, exactly like the last one.
Yes.
We will check the fluid again, although we suspect it's still going to be negative, but we always check it when we go in. And the one additional thing is after we take fluid out, we take about 10 milliliters out, and I will put in a total of 10 milliliters of chemotherapy and saline to replace that volume directly into that area.
Okay.
In general, he doesn't even notice when we give him the chemotherapy. People don't feel it going in. Even though you think you have all those nerves in there, you don't actually feel that space. So he won't even notice any difference. There is a risk of a headache, just like with the normal lumbar puncture.
Mm-hmm.
Of course, we use sterile technique to reduce risk of infection. And there's not a lot of bleeding, but we do put a Band-Aid and hold pressure afterwards to stop any bleeding you might have.
Okay.
Now, side effects from the methotrexate, which again generally don't happen when we just give it into this space, does include things like mouth sores, nausea, vomiting, or kidney damage. But the way that those happen is if the methotrexate gets to the mouth or to the kidneys or to the stomach, which it won't. So down the road, if he got this by vein, he might get those things, but he should not get those side effects with this. It can also lower your blood counts. Again, it does not get into his system, so it should not cause that. Plus, he already got chemo that's going to be much stronger than this anyway, so that's going to be a very minimal side effect for him. And the other thing it causes is kidney damage, which is why we can't give it to him now by vein. But when we give it into the fluid around the brain, like I said, it doesn't actually get to the kidneys, so that's not going to be as big of a deal for this. It's been shown to be safe giving this in patients with kidney damage.
Okay.
So those are the side effects. Really, the only side effect I suspect that he could get is a headache, which again is common with lumbar punctures in general.
Right.
Okay?
Okay.
the procedure we were planning to do this afternoon after he eats will take another 20 minutes. I pushed the chemotherapy over about 5 minutes, so
He's not going to eat that.
you're not going to eat. We'll still give him a little bit of time. Not hungry? No. Okay.
They ordered it because I didn't know if he could eat
That's all right.
before this procedure, so I
He
didn't.
can. There's no
His
problem.
nurse ordered it, and that's fine. You could eat the ice cream.
Yeah. We don't sedate him. He doesn't have to lie on his stomach, so there's no problem with
Oh,
eating if he wants to.
okay.
He can do what he can, and then we'll come and do this in a little bit. I will need you to sign for him if you're willing to let us do this chemotherapy. Do you guys have any questions about anything?
I do have just a couple. We're all set for Dad to have the chemotherapy. I just need a few more clarifications, if that's okay.
Okay.
So, Dad did not get the full dose of the cyclophosphamide and the vincristine because of the altered kidney status. Was there any
We dose
reason?
reduced it.
Correct.
Yeah.
So, is there any reason that you would need to do the catch-up dose now that he tolerated it well?
No, so we don't generally do a catch-up dose.
Okay. Okay.
Because his body saw more of the drug because his kidneys weren't clearing it as quickly.
Okay. That's
so we
fine.
gave him a smaller dose thinking it's probably going to have the same effect because your body doesn't clear it as well.
Okay.
That's why we do it.
Okay. So then
in the future, if his kidneys have recovered, when we give him the next dose, we may be able to give him the full dose.
Okay.
But we're not going to give him extra, if that makes sense.
Okay, I understand. That's great. So then
Yeah.
the other question is about the methotrexate. So
Yeah.
originally when Dr. Broadham talked about the lymphoma, protocol, that wasn't on there. So has that been added because of the additional concern about
Yeah, when Dr. Hess looked at the pictures that we finally got, we got the scans from the other hospital
Okay.
involving the adrenal glands.
Okay.
Lymphoma that involves the adrenal glands. Also, suppose he doesn't have this, but if it was involving the testicles also, those are two places that we know if it's there, there's a very high chance that it can spread into the central nervous system.
Okay.
So we know that by looking at a ton of patients that we've looked at over the years and treated.
Okay.
So in those patients, because the risk is so high, we give prophylactic treatment to the CNS, even if it's negative right now,
Understand.
to prevent the spread into that area. Because honestly, if it gets into that area, it becomes very, very hard to treat. And although right now we think there's a chance that we could cure him, if it got into the CNS, it would almost be impossible to cure him completely of this.
Okay.
So that's why we want to do it. We want to prevent that from happening because there's a higher risk. And based on the evidence we have looking at patients in the past, it's definitely worth giving this chemo to prevent that from happening.
Okay. Understand. And then would we then add the methotrexate to Dad's protocol for subsequent cycles?
Correct. Either by doing this again if his kidneys haven't recovered, or if his kidneys have recovered fully, we may be able to do it by vein instead of by lumbar puncture.
Okay. Okay. All right. That makes all good sense to me. I understand that. So when you guys rounded this morning, Mom didn't have the phone on so I could hear. And I know they had discussed a little bit about needing the 6 cycles instead of 4 and some concern about Dad's age and all the other comorbidities that have been going on. One thing I didn't know is, because we didn't really talk about lymphoma as much the last couple of days because we were so focused on kidney status, is does lymphoma get staged like soft tissue tumors? And if so, where is Dad in that?
It does get staged, not the same way, but it gets staged. So specifically, he has diffuse large B-cell lymphoma. So the first thing we want to know is whether or not the disease is on both sides of the diaphragm, which is the lining right below the lung. So if it's above that or below that. If it's just on one side or the other, it could be stage 1 or stage 2. Okay?
Okay.
If it's on both sides, it's at least stage 3. And stage 4 disease means, does it involve something other than lymph nodes and possibly in the blood? And the answer to that is yes, because we know he had that mass around his kidneys and his adrenal glands. So he's a stage 4 diffuse large B-cell lymphoma. And so that doesn't mean the same thing that you think of for someone like with lung cancer or breast cancer.
Yeah, no, I understand.
Because we can still offer a chance of treatment for that type of lymphoma.
Right.
And if he was 40 or 50, and we could have given him the full dose, and he could get 6 cycles of the full dose, which is actually called R-CHOP because there's an extra medication that we couldn't give him. With that, there's actually probably about a 2/3 chance of a cure. What Dr. Hess was saying is because we had to dose reduce and we couldn't give him the extra drug because of everything that went on, and we may not be able to, the cure rate will be a little bit lower. Okay?
Yes.
But we have to balance everything. If we gave him toxic chemo, we could kill him.
Yes.
We're already giving him toxic chemo. So,
right.
although there's a less chance of a cure, we are, regardless, we think we should be able to get him into a remission from this.
Right.
It's just the chances of it coming back might be a little higher.
Okay, that makes great sense. So then my one last question, which isn't really about the lumbar puncture, but I have you, so I'll ask. So my concern all along has been they've not been able to do a cystoscopy and biopsy that bladder to confirm that that mass is not soft tissue versus lymphoma. And I know Dr. Baradam said that that would probably have to be done outpatient. But so it will be, right? We'll follow up, we'll get that done. But if it ends up that we're looking at 2 different types of malignancies, does that mean then that you guys, you know, I know it said Dr. Houghton back in Myrtle Beach could handle things, but if we're looking at a bigger and more complicated process than Dad already has, can we continue to use?
Somewhat more complicated, but I will say that bladder cancer is a little different, right? So the concern was this was bladder cancer or kidney cancer that had spread outside and would have been stage 4, right? Which would have been not curable.
Right.
However, we now know that what's outside the kidneys and bladder might just be the lymphoma. So he could have a bladder cancer that's an early stage just in the bladder, which might mean that they might just be able to cut it out and give him chemo into his bladder and also cure that.
Right.
So while it's worth looking at because if he has a bladder cancer and we do nothing about it, it will spread. If it's early, we may be able to cure both things.
Okay. Understandable.
Okay? And so it's important to look, not so important to look immediately when he's still recovering from all this stuff.
Understand. Okay, great. Thanks for explaining that. I appreciate it.
And if it's bladder cancer and it's local, the urologist might just be able to handle that.
Right, and do like some BCG infusions and
exactly.
Right.
And so that would not necessarily require him to come see us, or I mean, it would be complicated because of 2 malignancies.
Yes.
Dr. Hess, actually, since he's the specialist in lymphoma, he would like to at least see you guys once to come back here, just so he can make sure that everything's going well.
Great.
Dr. Houghton is good, and they'll communicate, and he can probably get his treatments locally. But because Dr. Hess is a lymphoma specialist and Dr. Houghton is not, a lot of times they both appreciate it if Dr. Hess can also follow along.
Sure.
So we'll probably plan to schedule you guys to see Dr. Hess again at least one time so he can be in the loop and make sure everything's going well, and he can help make the decision about whether we can increase the dose next time, if we could possibly even give him the full R-CHOP.
Okay.
So that's, he does want to be involved. But we understand it's a long drive, so we'll definitely work with Dr. Houghton.
Okay, that's not a problem. We'll come as many times as you need to see Dad.
Yeah.
The other question is, Ginger, what about which office they're dealing with? I don't really know, to be honest.
Oh, we don't need to worry about that now, Mom. It's okay. That's just logistics.
In Dr. Houghton?
No.
Oh.
Is Dr. Houghton with that group up in?
No, Mom. Dr. Houghton is the oncologist. Okay.
Okay.
We need to follow up with Dr. Rich, the urologist, because just so your records, the doctor who did the initial prostate biopsy. We don't want to continue with, and we made that office know that during Grand Strand. It's a large group, Atlantic Urology, but now Dad's seeing Dr. Rich, R-A-C-H, and that's going to be who's going to follow up with Dad. Yeah.
Good. Our urologists are happy to help if they need to, but to be honest, that should probably be done with Dr. Rich, because that definitely does not need you to come back here for that.
Okay.
But I know that they were talking about it yesterday.
Yeah.
But it sounded like they were dealing with Dr.
Cicero.
Yeah.
Okay.
I'll make sure they know, and Dr. Rich's office can always call us here if somehow it gets, just get all the information and we can send them our records.
Okay.
All right. Awesome.
All right. So then we went from yesterday thinking Dad might go home today or tomorrow to someone mentioning this morning.
Still could. So one thing that changed is he started making a lot of urine, putting out a lot of urine, which is common and a good thing.
Okay.
However, we we do need to make sure that he's able to replace the fluid that he's losing. It's very common after a bad kidney injury that for your kidneys to start dumping urine, which is just part of the healing process. But he's not quite eating and drinking enough that we're confident to say, until we see that urine drop a little bit, that he could go home and...
Oh, you mean the amount?
The amount drop.
Right.
Okay.
Because yesterday he peed about 4 liters, and he's not drinking 4 liters.
Gotcha.
So that continued for several days. He would get dehydrated.
Yep.
So we
Okay.
just kind of want to see how he does. He could still go home tomorrow. It's not that anything necessarily got worse. We just want to make sure it's safe. We don't send him home to come right back to the hospital because he's dehydrated.
I agree wholeheartedly. Thank you for that clarification. So,
We're not going to send him home before it's too
I
soon.
know.
I
He had
know.
a full glass of water when he came back. He didn't want lunch.
That's fine.
Okay.
We're still working to try to send him home when it's safe. We just want to make sure it's safe.
But that's what she
Agreed.
said. Right.
Okay.
Okay.
from the bottom of
All
my
right.
heart, thank you for taking the time to
Yes.
just go over all that with us. I appreciate it more than you know.
We do appreciate it.
Okay, Mom, let him go get to work so he can help Daddy.
Okay.
Okay.
So we're good then?
Yep. Okay, Mom.
All right.
We'll talk to you after.
All right.
Okay, let them get to